Hi, my name is Leslie Polo, and my topic is enzalutamide in men with non-metastatic castration resistant prostate cancer. Definition: we hypothesize that enzalutamide with prolonged oral cervix among patients with metastatic castration resistant while metastatic in men with non-metastatic castration resident prostate cancer and rapid PSE11.
I think it's terrific that this drug is approved. It's validating the fact that even though these patients may have a serum testosterone level that's castrate, that further manipulation of the hormone axis will lead to improved outcomes such as survival in this situation. It's approved for second line after docetaxel. Again, like we're seeing with abiraterone, I would expect this to move up earlier. And in fact, one of the big advantages of this drug is that you don't need to give corticosteroids. And you can give it, but it's not required. And that has implications for immune therapy.
The treatment involved decreasing androgen levels. However, the tumor might progress to the prototype of castration resistant prostate cancer, which is still targeted on androgens and requires the androgen receptor products.
Working, but who don't have visible metastases on conventional imaging. Both of those studies were designed to look at metastasis-free survival as the primary endpoint, and both showed a large delay in progression to metastases or death with treatment. Now, the studies focused on higher risk patients. The majority of patients had PSA doubling times less than 6 months, and the median was between 3 and 4 months for PSA doubling times. So these are patients without metastases but relatively rapidly progressing disease, and it looks like we can delay metastasis or death significantly with either enzalutamide or apalutamide. Now, treatments are associated with some side effects, so those will have to be balanced against the benefits in an individual patient discussion with each patient in that situation.
Pros and cons. Pros: enzalutamide demonstration and highlight discrimination development in overlap source period of 4 months. Adverse data in terms of radiographic progression-free survival and time to first event. Cons is fatigue was seen slightly more frequently in the enzalutamide group.
Alternatives for these patients. I think at the end of the day, individual physicians are going to have to look at potential toxicities and decide if there's a difference. I can say that for apalutamide, in terms of other events, approximately 1% of patients died on the apalutamide arm without metastases, meaning from other causes. And that's the number we would expect. It's quite low. The number reported for enzalutamide was considerably higher. I suspect that reflects just the data not having been pulled together yet, and we'll see. But I think that's an important thing to be looking for, is to make sure that these drugs don't.
In such application in Ecuador, one of the most serious trials was the so-called prevalence clinic study. The results have led to the approval and a recommendation by the FDA agents, which regulate the use and the pharmacology in the user and the various parts of the world in the face of symptoms such as cancer.
So we have a large trial that supports the use of enzalutamide in M0 CRPC metastatic, non-metastatic prostate cancer with a rising PSA. The PROSPER trial showed almost a 2-year improvement in the development of metastasis. The study had not shown yet an overall survival advantage, but the benefits of delaying metastasis and the quality of life of men is very significant. So the opportunity to use enzalutamide in patients who have M0 castrate-resistant prostate cancer is a very promising development.
Conclusion. Among men with castration-resistant non-metastatic prostate cancer with a 5-ly increased PSA level, treatment with enzalutamide led to a clinically significant RX and less metastatic or diet than placebo. Adverse events were consistent with the established safety profile of enzalutamide.